and we'll be looking through diabetes, we'll be going through hypertension, we'll talk about myocardial infarction. We have the neurologist talk to us about stroke, and we'll also be talking about interventions that is available around us here for some of these disease conditions. And here with me this afternoon, I have my colleagues. First, I have the consultant physician and endocrinologist, Dr. Awofisoye, that will be talking to us today about diabetes emergency. And also on the panel that will be joining us later is Dr. Iseko, consultant cardiologist and our group medical director. And like I mentioned earlier, that we'll be starting today talking about diabetes. As we know, we just celebrated World Diabetes Day about 2 weekends ago to raise awareness about the increasing prevalence of diabetes in our environment. So, Dr. Awofisoye, can you just tell us what's the latest trend of diabetes in the country and worldwide?
Thank you very much, Dr. Olalekan. Like you rightly said, cardiovascular disease is a very serious burden now. And we know that the prevalence of diabetes is increasing. And that increment is especially in this part of the world, in low and middle income countries, especially in sub-Saharan Africa, which Nigeria is very dominant in. Unfortunately, we don't have a figure for the prevalence in Nigeria yet because of inadequate data. Okay, but we suspect that the prevalence is somewhere between 3 and 7% of the adult population, which is quite immense considering how big our population is in Nigeria. And yes, of course, we're talking about diabetes emergencies this afternoon, and we do know that as the prevalence of diabetes is going up, the increase in prevalence of both the chronic complications as the long-term complications and the acute complications will increase. And I think we are seeing more and more of that these days, and it's a cause for concern, especially a country like Nigeria, in which our purchasing power and the economy is not so buoyant, and diabetes, we know, is an expensive disease. So I think this is something worthy of discussion, and so that we are primed to do something better about it.
Thank you very much. As we are preparing to launch into the midst of the presentation, I want to remind us that we need to carefully listen and follow through to the end of the presentation in the host. And we should also remember that at the end of the presentation, we'll take comments, we'll take some questions. You can also send in your question through the question question room for us to take as we go along in the presentation. And before we eventually issue you the certificate of attendance, we will still ask you a little question about the presentation. So it is good that we listen and we pay attention very well. So about a month ago, during one of our clinic sessions, we saw a 50-year-old woman, a known diabetic of about 5 years, who has not been compliant with medications, and she came in with complaint of abdominal pain, vomiting. She had low-grade fever, and she was also complaining of frontal headache and mild chest pain. Our routine medications include telmisartan, metformin, vidagliptin, glimepiride, and she was also on lantus. But like I said, she's not been compliant on this medication and actually stopped taking this medication 5 days before she presented to us here. And she was actually weak and very, very, very lethargic with history of loss of appetite. What do you think about this case, sir?
Well, I think that's a common scenario. And unfortunately, acute presentations, we know that people with diabetes often have to come to the hospital more than other people for acute illnesses. The way hyperglycemia works, little infections that the body will have been able to clear on its own. Many times it often can down someone with diabetes and cause them to have to come to the hospital, especially if the diabetes is not well controlled, especially if the A1C is poor. And I'm not surprised in this kind of situation, in a lady that appears to be requiring quite a bit of medication. I can see that the person is on 3 oral agents and insulin in addition to that. I'm not sure what the glycemic control has been like. and now stopped the medication. If the medication is stopped like that, sometimes the blood glucose can go up. And in the context of a concurrent infection, it can actually quite spiral down. And I think that's part of the reasons why it's reported that even this ongoing COVID has worse outcomes in diabetes. So poorly controlled diabetes and infections don't really mix very well. So when you examine the patients, what were the findings like?
Okay. During our examination, we found a lethargic woman, a bit cold touch, and was dehydrated. The temperature was about 32.8. The BP was normal. There was tachycardia, and she was tachypneic. Abdominal examination, she had marked epigastric tenderness, but the chest was clear and there was no abnormality in the CNS. The urgent random blood glucose was very high, almost about 27 millimole per liter, with findings suggestive of infection on the full blood count. The urine, a lot of ketone, there was blood, and the ECG that was done showed tachycardia with left axis deviation.
Like how much ketones were on the urinalysis?
We find almost 3 pluses of ketone
in the urinalysis.
In the urinalysis. How would these findings affect the management of these patients?
Well, I think by the time we are seeing a patient with diabetes coming with severe weakness and an acute illness, we actually always have to ask ourselves the question that, is this a diabetic emergency? Is it an hypoglycemic emergency? Because that changes the whole attitude to the care of the patient. And yes, of course, the lethargy, the weakness is there, but by the time we hear abdominal pain or vomiting in a patient with diabetes, our antenna should really go up. That, okay, what is going on here? Is this a primary hyperglycemic emergency, or is it a concurrent condition, perhaps peptic ulcer disease, pancreatitis, or just any other ongoing infection that's presenting in a patient with diabetes? Whichever way it is, such a patient needs an urgent attention. And by the time we checked the blood glucose and we found that the finger stick is quite elevated like that, it's a cause for concern, and it almost tells us that we are likely dealing with an hyperglycemic emergency here. And you did say that the urine showed 3 plus of ketones.
Yes.
I'll be concerned about that, because even though she's 52-year-old, and we often say that diabetic ketoacidosis classically is commoner in type 1 diabetes and younger people, but we know that in her own environment, perhaps most of the diabetic ketoacidosis we see is actually in patients with type 2 diabetes, and we do see them in older people. And so yes, I would agree that this is a diabetic hyperglycemic emergency, and that leads us to introducing the spectrum of conditions that belong under the.
Let me stop you there before you start talking to us about the spectrum of diabetic emergency. Let me quickly welcome people that are just joining us. That this is the 4th Abuja Cardiovascular Symposium, and our theme for this year is practical approach to the management of cardiovascular disease. And also to remind us that as we go on, you can post your question online. You can raise your hand so that if it's possible, we can call you in between the presentation. But at the end of the presentation, we have enough time to take questions. But if you have any question, you can send to the chat box. So let me allow you to talk to us about diabetic emergency. What are diabetic emergencies, and what are the spectrum of these diseases?
Okay, so diabetic emergencies are conditions among patients with diabetes, of course, that require emergency, as opposed to urgent care. I think that it reminds me of the term hypertensive emergencies and hypertensive urgencies that we talk about in patients with high blood pressure. And of course, the main diabetic emergencies that we talk about includes the hyperglycemic emergencies, which includes the well-known diabetic ketoacidosis and the hyperglycemic hyperosmolar state, previously called ONC. That's a hyperosmolar non-ketotic state. Of course, we know that we can also have an hyperglycemic emergency state in which there's an overlap between the DKA and HHS, and sometimes we have severe hyperglycemia without it causing any serious metabolic abnormalities, the so-called normoosmolar non-ketotic hyperglycemic state. But the other extreme of the hyperglycemic emergencies is where we have hypoglycemia, which sometimes is not an emergency, but it can present as an emergency, especially if the degree of hypoglycemia is severe. Okay. So those are the things that will fall under the spectrum of diabetes emergencies.
Okay. And how are patients distributed in between all these spectrum?
Okay, beautiful. So talking about the distribution of patients, like I mentioned earlier, most of the patients we see with diabetic emergencies in Nigeria are probably adults, okay, but it can definitely also happen in children. And we know that globally, diabetic ketoacidosis, which is the hallmark of diabetic emergencies, is actually more common in children. And over the years, like I said earlier, the prevalence of diabetes is increasing. Over the years, because of this increase in prevalence of diabetes, we are having more diabetic emergencies. That's the truth. It just follows. So one of the studies, a US-wide analysis that was done up till, I think, from 2010 or so to 2014, actually did show that the prevalence of DKA was increasing, and it applies to most of the other diabetic emergencies. But the good thing is that the outcomes of some of these hyperglycemic emergencies are actually better than it used to be. Of course, this is partly due to better understanding of the conditions, more availability of insulin, and better healthcare, generally speaking. Okay, so the outcomes have actually improved over the years, and I mean, that's the good part. But the worrisome part is that the prevalence of diabetes continues to increase, and the prevalence of these complications as well continues to increase as well. There are many hospitals in Nigeria, teaching hospitals in Nigeria, that have actually looked at how common we have these diabetic emergencies. And of course, many of them report a variable proportion, okay? But one of the highest proportion that we do have is from FMC Makurdi, in which diabetic emergencies did constitute about 30% of the patients that were admitted totally for them, okay? The only other condition that is more uniformly commoner for medical admissions than diabetic emergencies is diabetic foot ulcerations. Of course, the studies are skewed, and there are different reports based on which criteria is used, which test was used to diagnose the diabetic ketoacidosis as different from hypoglycemic hyperosmolar state. Okay, but aside from diabetic foot and infections, perhaps diabetic emergencies is one of the commoner causes of hospitalization, acute hospitalizations in people with diabetes. It's also noteworthy that the condition that leads to the most prolonged hospital admission are diabetic foot problems. So we can see those prevalence on the slides there, and diabetic emergencies remain a problem despite the advances in its treatment, and despite the more successes we have treating this condition, it still comes at us, and we think we can do something about this.
Okay, thank you. And talking about the pathogenesis, is it infection or diets that causes diabetic emergency?
Well, diabetes emergency actually, a lot of things actually have to go wrong for someone to have a diabetic hyperglycemic emergency. Now, talking about the high sugar emergencies, a lot of things have to go wrong because the body actually has some inherent processes that it tries to, even if the blood sugar is trying to go up, that it tries to use to suppress it. Of course, we know that these processes are failed in diabetics, and in people in which the diabetes is either type 1, in which there's almost absolute insulin deficiency, or a long-standing type 2 diabetes, or a type 2 diabetes person with a lot of insulin resistance. Some of those processes are actually subdued as well, okay? Part of the mechanisms of the body in preventing hyperglycemia, for example, is osmotic diuresis, in which the kidney can flush out both glucose and water, okay? And of course, subduing these counter-regulatory hormones. But in looking at the pathogenesis, we cannot understand the pathogenesis of hyperglycemic emergencies without talking about the metabolic effect of insulin. And insulin has many activities it does in the body, and all of this culminates in regulatory mechanisms. You can see on these charts, acts on skeletal muscles, acts on the liver and on the adipose tissue. Now, the things we expect when insulin is working very well, we expect many effects. Increase in glycogen synthesis, reduction in lipids, fat tissues are built up, and metabolism. Of course, we know that insulin is not available to do these things that it would do. And really happen really fast, especially if the insulin levels is really low. So we can see that if the insulin is deficient, if there's a lot of insulin deficiency in a particular person, we can have a lot of tissue breakdown. And I think that is actually the key to understanding hypoglycemic emergencies, both the diabetic acidosis and the what you call this, hypoglycemic state. So talking about the pathogenesis of DKA, the previous slide, talking about the pathogenesis of diabetic ketoacidosis, central to this, again, is insulin deficiency. In fact, when we're comparing DKA to HHS, what we say is that the amount of insulin deficiency in DKA is so severe, it's much severe. That is, the insulin levels are much more lower in DKA compared to the HHS. And the insulin is low such that the body is unable to utilize glucose. So glucose is not entering into the liver, it's not entering into the skeletal muscles. Lipolysis is happening in an unrestrained fashion. So lipid tissues are being broken down, beta oxidation is taking place, and then of course ketone bodies are being generated. Of course, we still have proteolysis going, that's protein synthesis reducing, protein breakdown increasing, and all of this leads to, number one, excess glucose in the blood, which leads to unrestrained hyperglycemia, one, and of course it leads to a lot of ketone bodies that are generated, and we know that these ketone bodies are acidic. We have acetone, we have acetic acid, and we have beta hydroxybutyrate. All these are acids, and even though initially it's a compensatory mechanism because some critical tissues in the body, particularly the brain, can utilize ketones as an alternative source of fuel, at least for a while, okay? But in patients with DKA, these ketone bodies can rapidly build up, especially when they get dehydrated and the kidneys are unable to excrete the ketone bodies as rapidly as they ought to. We should also put in mind that there's a delicate balance in all of us actually between insulin levels and activity and the counter-regulatory hormones which counter insulin activity. These counter-regulatory hormones, we know them very well. They include cortisol, the growth hormone, the catecholamines, adrenaline particularly, and the glucagon. So there's a delicate balance between this, but when insulin really gets weaker and the insulin levels are low, then the activities of these counter-regulatory hormones, which actually work to work up the body and to increase the level of glucose in the body, they happen in an unrestrained fashion. And we have this hyperglycemia, and we also have ketoacidosis. And in the context of reduced renal excretion of the ketone bodies, these things build up in the body, and we start having a lot of problems. Now, going to the pathogenesis of HHS, that's of the hyperglycemic hyperosmolar state, is actually quite similar. The only key difference is that the amount of insulin deficiency that is in a patient with HHS is sufficient. The amount of insulin that is present is sufficient enough to inhibit lipolysis. So there's some lipolysis, but it's not as crazy as we have in a patient with diabetic ketoacidosis. So the amount of insulin is not as absolute as in such as in with. And then the second thing is that dehydration is actually critical to the development of hyperglycemic hyperosmolar state. We should remember that we have in from the hyperosmolarity. And of course, if someone is actually getting enough hydration, it's actually very difficult to develop HHS. So the dehydration and of course the hyperglycemia, all of them work together, connive together, and it leads to the HHS.
Thank you very much for the pathogenesis well explained. The patient I mentioned earlier had a lot of ketone in the urine. Is the presence of ketone in the urine the only factor to distinguish of different type, or are there other ways to differentiate between a patient having a DKA or HHS?
I think that's a key question. I will say that even for experts, sometimes it's difficult to distinguish between HHS and DKA. And I'll tell you that many people actually, when they find it difficult to distinguish, they just name it an overlap syndrome. We should put it in mind that DKA and HHS, they are conditions at two ends of the spectrum of hyperglycemic emergencies, but just depending on how much insulin deficiency we have in this state. So there are many key factors that we use to distinguish between the HHS and DKA conditions. And of course, the amount of ketone in the blood is one of the critical ones. But of course, we know that in our practice in Nigeria, it's more difficult to have serum ketones done. It's only a handful of labs that run that. Okay, so urine ketones is quite useful, very useful actually. Of course, it has its own limitations, but by the time we are having a patient with diabetes, with diabetic emergencies, and we have about 2 or 3 clusters of ketones in the urine, it strongly suggests that we're dealing with diabetic ketoacidosis A. But from the name, diabetes ketoacidosis, metabolic acidosis is actually also very critical to defining that someone has DKA. And usually for that, we'll expect the pH to be less than 7.3 or less in labs where we have venous I-stats that gives us the venous pH level, or serum bicarbonate less than 18 is suggestive, or we have anion gap, anion gap metabolic acidosis. So those are the things that can actually quite suggest to us that we're dealing with a patient with diabetes ketoacidosis.
Okay, thank you very much. We've been talking about diabetic emergency. We've gone through the introduction, we've gone through the different type, and we've talked a lot, don't let me say a lot about the pathogenesis and the way to actually differentiate. And to ensure that we're following, we just want to quickly ask some few questions to check our level of concentration. So we'll be happy if you quickly answer this question.
Okay, so let's attend to the poll now and just.
So we have a 40-year-old woman admitted with polyuria, lethargy, and fever. Our random blood glucose was 650 milligrams per DL. So let's answer the question.
Let's attempt the question.
Okay, thank you. I can see people attempting and giving us good response. Thank you very much. So we'll end the poll in the next 10 seconds.
20 seconds.
Okay. Okay, I was told to add 15 seconds more for more people to make attempts. Okay, 5 seconds more. So we can end the poll now. Let's look at people's response. So Dr. Awofisoye, what can you tell us about this question?
So we have this clinical scenario: a young woman with polyuria, lethargy, and fever, and a RBG of 650 milligrams per DL. So the serum osmolality of 330 is actually suggestive more of HHS. The cutoff is about 320. So most people with DKA have osmolality between 280 and 320. But 320 and above is more suggestive of HHS. So the first question is wrong. And then the normal serum bicarbonate makes DKA very unlikely. That is true, because that DKA is defined by metabolic acidosis, and the bicarbonate should be reduced, except people that have mixed acid-base disturbances. Anion gap of 20 is not elevated, so it's elevated. I'm happy most people got that. And then level of consciousness is affected more in DKA. No, level of consciousness is actually affected more in HHS. We should not forget that the osmolality is what causes that level of consciousness to reduce. But I think I'll highlight more of this as we continue the presentation. Thank you very much.
Thanks for making the attempt. So someone is asking us, are we going to make this slide available at the end of the symposium?
The videos will be made available, yeah.
Okay, so you don't have the problem. You get the video, you see the slides too.
Absolutely.
At the end of the program. So what are factors apart from maybe like I mentioned in the patient who presented that the patient stopped taking medication? Is poor adherence the only prescription for hypertensive emergency?
You know that for diabetic emergencies, you know that we see a lot of patients with hyperglycemic emergencies, and even among patients with poor adherence to medications, very frequently the far most common cause of as a precipitant error is actually infections, and the common
Any
ones,
kind of infection.
Almost virtually any kind of infection can actually trigger a diabetes because of the circles of what they call the vicious cycle that an infectious condition creates in a person with hyperglycemia, especially if the glycemia is not well controlled. Like for example, during the COVID crisis, I'm aware of quite a number of patients that with diabetes, the sugar just went up, and then they diagnosed them that they have an ongoing infection, and then they found out that it was actually COVID that they have. So any infection can actually make the glucose spike up. But the common ones that we do see includes respiratory tract infection as in pneumonia, urinary tract infection, sepsis, malaria. So those are quite common. And then sometimes we see patients that are just being diagnosed with diabetes. They didn't know they had diabetes. They just started having the symptoms. Maybe they ignored the symptoms, for instance. And then they now realized, they now came to the hospital and then they came in DKA basically. Then of course, we know that some patients are on insulin, just like the patient you described in the case scenario. She stopped her medications, including insulin. The sugar is going to spike up. So yes, that is known. But sometimes too, we have people that start certain medications that are known to make the blood glucose go up. And such medications, the commonest one includes steroids and some antipsychotic. There was a lady that was started on steroids for nephrotic syndrome. And her glucose was normal before starting. Within a few days, she was more than 800 milligrams per day, even though she didn't go into the hyperglycemic crisis because she was being monitored, sort of. Okay, so other serious conditions such as acute myocardial infarction, stroke, pulmonary embolism, pancreatitis, trauma, even pregnancy are things that sometimes trigger diabetes ketoacidosis. And I will say that it's actually something we should pay a very serious attention to, that, looking for the precipitant. Because sometimes if we don't find the precipitant, the person will never come out of DKA. That's the truth.
Okay. I'm happy that you mentioned that diabetic emergency can actually be the first presentation in a patient that was never known to have DM before.
Absolutely.
And now going to the practical approach of it, how will every doctor, even at the most primary of the centers we have in Nigeria, be able to recognize a patient with diabetic emergency?
Thank you very much for that. So in recognizing, number one is that we should have a low threshold for checking blood sugars. That's the truth. We should have a low. In our center here, you know that we have a policy that anybody that is admitted should have a blood sugar test, except if it has been tested very recently. That helps us, prevents us from missing a lot of cases. And I'm aware of a story of a certain person that was admitted in an emergency room in one hospital somewhere.
Sorry, we may actually put up the slide for the clinical features.
Yes, please.
Continue.
So was admitted in the emergency room. She presented with abdominal pain. She was being seen by the surgeon, went to do ultrasound. I think she even had a CT scan before someone thought to check the sugar. And by the time they checked the sugar, they did all the right workup. It was actually diabetes ketoacidosis she was having, and she had spent maybe perhaps more than 48 hours before. So we should have a low threshold for checking the sugar. That's one. And the other part of that is that, of course, we should be aware of the symptoms that can be attributable to diabetes. And the clinical features, like we have on the slide, includes the classic osmotic symptoms of diabetes. And in patients with DKA, if we get that patient with diabetes that has that deep sign breathing, that we call cosmos breathing, we should think that, could this patient have diabetes ketoacidosis? And just like the patient you presented, the thing that often gives it away in the context of that breathlessness is that the chest will be very clear. And that tells us that that's just air hunger, metabolic acidosis, and the person is trying to give a respiratory correction to the acidosis. The other kind of things that we have in patients presenting with this in DKA or even HHS includes mental state changes. Some patients can be fully alert, but some patients can be quite drowsy, and some are frankly comatose. But the mental status changes are actually quite more common in patients who have HHS compared to patients with DKA, like we saw in that poll that we talked about. Also, we should be aware that you can present with focal neurological signs. There's a story I often tell people. While I was doing residency, there was a patient we saw. Patient came in the night. Everybody has said he had a stroke, and I actually took it that he had a stroke too because he was just frankly unconscious out of the blues. I mean, he was just very unconscious. The history that is a known diabetic was not taken, was not obtained, and many other things, and they've not checked his blood glucose still there. And lo and behold, we checked his blood glucose. His RBG was not terribly low. It was around 65 or 62. And the guy has been unconscious for 4 hours in the emergency room. They were preparing for a CT scan, and by the time they did his RBG was very, very high. Okay, so it can present with focal or global neurological features, particularly in patients with HHS. And then, of course, we can have even the blood, the temperature can be normal, low, but we should not be fooled by low temperature because even someone with a very severe infection can be hypothermic.
So apart from checking the blood sugar, what are the other relevant investigations that we can quickly do to assist us?
I think after checking the blood sugar of a patient with diabetes, the next thing a physician should want to look at is actually the urine. And we know that urine biochemistry is something that we can get the result of within a few minutes. So get the urine biochemistry done and know whether this patient has ketones in the urine or not. Of course, while we do that, we're also waiting for the electrolytes, urea and creatinine, the blood count to see if there's anything that would suggest an ongoing infection. Of course, we should put it in mind that in patients with diabetic ketoacidosis and even HHS, but more of DKA, they can actually have leukocytosis without necessarily implying infection. We should remember that when we do the EU and creatinine, we should calculate the anion gap. We should calculate the anion gap. We should know whether it's elevated or not. It's usually quite elevated in DKA. It can be slightly elevated in HHS because of the lactic acidosis that they may tend to have sometimes. And apart from calculating the anion gap, we should also calculate the serum osmolality. I wanted to put the formula, I didn't remember to put it. Okay, but usually we calculate the serum osmolality using the sodium and glucose levels in the blood. And with that, we can find out, of course, we add urea sometimes, okay, but many times we can safely ignore the urea. The anion gap is calculated by the sodium and potassium minus the chloride and bicarbonate, okay? And usually by the time the anion gap is getting more than 12 to 16, depending on whether potassium is there, it is elevated. Apart from that, we need to hunt for the precipitant of the DKA, because if we don't treat the precipitant, it may be difficult to get the patient out of the hyperglycemic crisis. You just see that as the patient seems to be improving, the patient starts getting worse again, or the patient may not even improve at all. So we need to identify and treat the precipitant. And I mentioned earlier that one of the most important precipitants of the hyperglycemic crisis is infections, okay? So apart from the full blood count, ESR, CRP, or inflammatory markers, we should take cultures, blood cultures, urine culture, sputum culture in someone that is coughing. We can do a chest X-ray if we think it's normal. And in patients with persistently depressed CNS, a patient that remains frankly comatose, not improving, we should have a low threshold for doing a brain CT scan. We should also remember that DKA treatment can be complicated by cerebral edema, which we need a brain CT scan to diagnose. Of course, most people with hyperglycemic emergencies will not need a brain scan. Okay, but if they're deeply unconscious, or if the osmolality does not explain the level of unconsciousness, for example, osmolality of about 310 millimoles per kg cannot explain someone being unconscious. And so basically, those are the investigations that we want to do for this patient.
Okay, so before you walk us through the treatment, I want to ask, as a doctor in a primary care setting with a patient presenting like this, is it just for me to just pack the patient and send that? Or is there anything I can do, even if I'm going to send to an higher center? Is it just to say, oh, no, we cannot manage this one? Are there steps I can take before I send this patient to the specialist for management? Or can anybody just continue to manage diabetic emergency?
For diabetic emergencies, for a clear-cut HHS or DK, I think it's better managed in a specialist center where there are people that are dealing with this all the time. But of course, there's a definite level of initial management that can be done by virtually any doctor, or even many nurses. Okay, fluid therapy is key. Now, okay, so first of all, of course, the assessment needs to be made. Fluid therapy needs to be started as soon as possible. And as soon as the fluid therapy is established, the patient needs to get some doses of insulin. It's better the patient even gets some dose of insulin, at least one dose of it, even before transfer, because that would sort of not abort the process, but it will limit the process. Because don't forget that is an extent of insulin deficiency or absence or lack of insulin that's actually making the person go into the hyperglycemic crisis. So those are some things that can be done before referring the patient. But we know that patients with HHS and DKA, they do better when they are managed in an HDU or a high CU setting. Most patients with DKA will need that kind of intense management within the first 12 to 24 hours. If they are managed well, even patients with DKA can be discharged on the next day, because it's something that actually resolves very fast. Of course, I can't say the same for HHS, because HHS, many times the underlying, the persistence is often severe. These patients are often older, and many times the recovery is probably much slower.
But I don't have insulin in my center. Can I give these patients downhill, glucophage, or glimepiride? What do you think?
Before that, I think we should take a poll. Let's take the next poll,
okay.
Please.
Okay, let's attempt this poll.
No, it's not started. This is the old one. This is the old one. End polling.
Okay, end polling.
Arrow down, upstairs.
Okay, poll 2. So let's take this poll. Sorry, I was in a haste to rush to the meat of the treatment. So a 49-year-old woman was admitted with polyuria, fever, malaria. RBD on admission was 650 milligram per DL. She had ketonuria and tachycardia, normal blood pressure. So which of the following is the appropriate initial management for these patients? Okay. We want more people to attend that question. Thank you. I can see people coming up. Okay. 15 seconds to go for the poll. So what is the appropriate initial management? Is it to give IV fluid, start antibiotic and metformin? Is it ringers, mid-card insulin? Is it normal saline and insulin? Start insulin and radiation simultaneously? Or start IV fluid and give glucophage and glimepiride? What do you think is the best approach? So okay, we can end the poll now. And Dr. Awofisoye will answer that and at the same time answer my question about, can I just give, I don't have insulin?
Absolutely. I think it was a good question. I think the poll was timely. So in this kind of patients presenting with an hyperglycemic emergency that looks like a diabetes ketoacidosis, most people chose start insulin and rehydration simultaneously in view of the severe hyperglycemia. And then the next well-chosen question is the commence normal saline, then later regular insulin. The right answer is actually the starting the insulin later. In patients with hyperglycemic emergency, it's actually more appropriate to rehydrate to some extent first before insulin is started. And there are many reasons for that. First reason is that your insulin cannot circulate. Don't forget that in the pathway to develop pain hyperglycemic emergencies, the most senior guy on the list is actually the dehydration. It's the dehydration. And if you don't sort out the circulation, the insulin will not even really circulate well. It will stack, and then so that's one. So hydration, and then secondly, the glucose can actually come down to a reasonable extent. You can be surprised sometimes. It can come down to a reasonable extent just by rehydration alone. Okay, so usually the patient should be rehydrated with for at least about 1 hour, with at least 1 liter or more of saline before the insulin is commenced. It also gives us time to have the electrolytes tested and then see the trend of the blood glucose. Okay, so The third, so basically we should not do that. Then second question that Dr. Olalekan asked, which is a good question because I've seen people try to manage hypoglycemic emergencies with oral agents. We cannot manage hypoglycemic emergencies with oral agents. We should not forget that metformin is contraindicated in the presence of any extent of acidosis or even ongoing sepsis. And at that time, the insulin management system, that's both production and the action of the body is stressed up. And this is not the time to start using some medications that will act on the pancreas that will act on the other system. So we need to replace there's no way we can manage hypoglycemic emergencies without insulin. Of course, we start the fluids, okay, but then after the fluids come the insulin.
Okay, people would like to know, how do you titrate your insulin along with your glucose level, or you just keep giving the insulin until the patient just suddenly wakes up and...
Okay, yeah, so I agree with you. Okay, so I'll talk a bit about that, but I want us to talk about the fluids a bit first.
Okay.
Okay, so we've established, we mentioned earlier that the patient should be managed in a very monitored ward, preferably an ICU and HDU. So before the insulin is given, we would start the fluids, and the ideal fluid we typically give is normal saline, okay? Ringer's lactate can also be used, but normal saline is generally the preferred fluid. And the fluid will be started fairly fast and de-escalated. So typically, of course, the amount of deficit is quite variable, and some people can have deficits up to even 10 liters in HHS, okay? So we start fast, and then we slow down. So typically about 1 liter fast, 1 liter about 1 hour, 1 liter about 2 hours, then 1 liter 4 to 6 hourly, depending on how dehydrated we think the patient is. Many patients will need to have at least 2 IV lines, okay? Because of the insulin infusion that you will need to start as well later, okay? Because of concerns of the chloride going high, the amount of fluid deficits that these patients have, many times the amount of normal saline we'll have to give them can push their sodium up, can also push their chlorine up. And that's why some people actually recommend using Ringer's lactate after the first few batches of first few pints of the IV fluids. But invariably, when hemodynamic state is restored, ideally we should change to have strength saline, which unfortunately is not locally available, is not often available in our settings. Of course, the patient needs to be continually reassessed fluid-wise, because it's easy to fluid overload these people, especially for children. We should watch out for cerebral edema. And we know that if we give them too much fluid, they can have pulmonary edema or cerebral edema. If we give them too little fluid, we will delay their recovery. And if somebody lasts too long in the ketoacidotic state, it can increase the chance for arrhythmias and cause a lot of other problems in the body. So it's not a state where we want someone to last too long.
Can you not talk about that insulin before?
Yes. So for the insulin therapy, typically typically soluble insulin is used. Ideally, it should be through an IV infusion pump. Okay, but most times in this environment, we have to use deep iron insulin sometimes. Okay, some people give their insulin through in a bag of normal saline, but I won't really recommend that because you can't guarantee the flow rates, and the patient can go into hypoglycemia, or we can have an erratic rate of drop, so to say. So typically we start at about 0.1 units per kg, which usually translates to 7 to 10 units per hour. So usually 7 to 10 units per hour. Typically we use 10 units every 1 to 2 hours initially, and that is given repeatedly. I'm talking of when we're using deep iron insulin, and that's given initially until blood glucose drops. We should not be in a hurry for the blood glucose to drop, and we should not forget that when our glucometer reads high, that's above 600, it can be 900, and the fact that after 2 hours you check it's still high does not mean it's dropping. Okay, and that's why we should always try to see whether we can get a proper quantitative assessment from the lab, so that we can know the exact figure and we know when it's dropping. Okay, so we should continue the insulin, either deep iron insulin 1 to 2 hourly, or the insulin infusion until the glucose drops to less than about 250 milligrams per dl. And the rate at which we want the glucose to drop, we want it to drop about an average of 100 milligrams, 50 to 100 milligrams per dl per hour. If you're getting more than that drop, it's probably too fast. And if it's too fast, it creates the risk for other problems, including rapid decline of potassium levels, and increased risk of cerebral edema in patients you are treating for diabetes ketoacidosis. Okay, so subcutaneous insulin is not recommended, even though some people have done studies on trying subcutaneous insulin in hyperglycemic emergency with various success rates. But because of the peripheral vasoconstriction we have in patients with that extent of dehydration, the absorption of subcutaneous insulin is likely going to be very erratic, and it's not recommended. So usually when we give this insulin either as an infusion through a injection pump or the intermittent deep iron insulin, by the time the glucose gets to less than 250 milligrams per DL, we need to start a concurrent glucose infusion. A common mistake that people make at this time is actually to stop the insulin. Okay, you should not stop the insulin at that time, because the insulin is not just to control the glucose levels. No, you're trying to control lipolysis, you're trying to restore the anabolic state of the person. And until that is done, the insulin should not be stopped. Rather, you should add a concurrent glucose infusion. And of course, we continue to adjust the rate of the insulin just to keep the glucose within the desired range.
Okay, thank you very much. Before we start taking questions, we have a lot of them. There is one diabetic emergency that we usually forget, because when we hear diabetic emergency, every antenna is turned towards the sugar on the ice. What about hypoglycemia? Is it also an emergency that we need to talk about briefly before we start taking questions?
Well, hypoglycemia is actually very common. The more is actually, some people have described it as the neglected diabetes emergency. The truth is that the more diabetic people we have, the more people with diabetes that are on treatment, the more iatrogenic hypoglycemia we're going to have. Okay, and we usually define hypoglycemia as any level of blood glucose that exposes a person to a risk of harm. Okay, usually by the time it gets less than 70 is hypoglycemia in someone with diabetes.
Well, can it be relative, or is this just an absolute that, okay, until the blood sugar is at this level, someone cannot have feeling?
Absolutely. So you're right. There's that concept of relative hypoglycemia in which even at levels greater than that 70, perhaps even at 90 or 85, someone is having hypoglycemic symptoms. And that is typical in people who have been exposed to very high glucose concentrations for long. Okay, so their body is used to that, and then the threshold for hypoglycemia is much higher than it should be. Okay, but hypoglycemia, that relative hypoglycemia in that range is actually typically relatively harmless. Now, but if you're going to look at the severity of hypoglycemia, we classify hypoglycemia into mild, moderate, or severe. Of course, by the time someone has hypoglycemia that is bad enough for him to require help to treat the hypoglycemia, it is severe. And it's a functional definition, because if I have hypoglycemia now and I cannot treat it, I'm impaired to the extent I cannot treat it myself, it means that if there's nobody around, it can lead to something else, which you don't want. So that's severe hypoglycemia. Of course, the mild hypoglycemia is those that have just autonomic symptoms. That's just the the palpitation, sweatiness, and all those adrenergic symptoms. But by the time someone has neuroglycopenic symptoms such as tiredness, drowsiness, fatigue, we should be getting more worried, because that's okay. But unfortunately, some people have what we have called as hypoglycemia unawareness, and they may not be able to know when they are going to have hypoglycemia. So they won't have those autonomic symptoms. They just progress straight to the neuroglycopenic symptoms.
I'm sorry, I will have to stop you. I'm sure we answer some of these other questions about hypoglycemia when we're taking the question, because we have to quickly take people's question because
of time.
Another presentation is coming up shortly. So
let me read a question for you. I'll read a question. It says, in a low resource setting where there is no available lab for EUCR, United other investigations, what are the clinical elements a clinician should consider in patient management?
That's a difficult one, because we need those tests actually, and it's very difficult to treat based on suspicions alone. But I will say that if a patient with diabetes comes in with hyperglycemia, I would see clear-cut features of ketoacidosis, even without your here and you, I think it's better to treat as such than to treat as just a normal hyperglycemia that is not an emergency, and then we run the risk of losing the patient. So those clinical features of diabetes ketoacidosis can be helpful, which includes the Cosmos respiration, which is classic, the acetone in the breath, which is fairly classic too for those people that can smell it. Unfortunately, I can't. Okay. Then, of course, if there's vomiting, abdominal pain, those can be quite suggestive. I'm happy that urinalysis, which is again key for diabetic ketoacidosis, is more widely available and does not require any fake laboratory equipment.
So, is there any role for glycated hemoglobin
Yes,
in diabetic emergency?
Absolutely. So there's a role for glycated hemoglobin in diabetic emergency. The role is limited actually, but everybody with diabetes must have a glycated hemoglobin, and it just lets us know how bad the issue is. I'll just give you a context for the interpretation now. If the glycated hemoglobin is on the lower side, let's say I'm getting like 6 or 6.5%, I will actually wonder whether it's likely something that is just developing within the last 24 hours. And that's classic for type 1 diabetes that is just developing. Unlike someone that has a HbA1c of maybe 10 or 12 or 14%, which suggests something that is more long-standing, okay? But its utility acutely is limited, okay? But it has to be done because we need a baseline, okay, to which we'll continue to
Thank you. Let's quickly take these two questions together. Somebody's asking that you said DKA is common in type 2 diabetic. Is that correct? Then someone says for someone with HHS, is rehydration enough without insulin?
Okay, so globally, DKA is common. DKA is more peculiar to type 1 diabetes and to children. Okay, but we know that the proportion of people with type 2 diabetes globally is more. So 90 to 95% of people with diabetes is type 2. And we know that in this part of the world, we have a lot of this so-called ketosis-prone type 2 diabetes. So we have a lot of them is the sub-Saharan African and Black American things. So we have a lot of that. And because we have a lot of that, most of the DKA we end up seeing are actually in patients with type 2 diabetes. So that's that part. Now, the second part is whether rehydration alone
without insulin
is enough for someone with HHS. The answer is no. The answer is no. And the reason why the answer is no for that is because in patients with HHS, there is insulin deficiency. There's only so, except if the diagnosis is wrong, but if the patient really does have HHS, then the person requires insulin as well. The amount of glucose reduction you can have with just rehydration, it's perhaps not going to be more than 200 or 250 milligrams per DL, and it's not enough to help the person to recover. So if someone has clear-cut HHS, rehydration will solve maybe almost half of the problem, but it's not near enough. So no, it's not going to be enough.
Someone asked that the fluid regimen you talk about, that is it the same for HHS or DKA? Then does that fluid, the rehydration, does it affect your blood sugar disorders? As in, you take the blood sugar before you start rehydration, or you take after? Does it affect?
Yes, of course it does. The blood glucose, I'm sure most of us know that the blood glucose, when we start rehydrating a patient that is frankly dehydrated, the blood glucose will actually drop by a certain amount, maybe between 100, depending on how dehydrated the person is. So it does make a difference. And to the other question, I think I lost the other question.
And the other question is the fluid regimen, is it the same?
Oh, yes. So the fluid regimen for DKA and HHS is largely the same. Of course, we know that the fluid deficit in HHS is way more than we have in DKA. So a patient with HHS will usually require more fluid than HHS. But the trick concerning the fluid is actually, number one, to match the intensity of the fluid to the amount of dehydration the patient has. That's one. And that's why there is no fixed value for the amount of fluid. And then we need to continuously reassess the hydration status of the patient. So there's a patient that you put on after the initial high rate fluid that will put the patient on 1 liter 6 hourly, and then you review the patient in 2 to 3 hours time that you say that let's give 1 liter bolus over 1 hour again, and then we now go to 1 liter 4 hourly. So it's something that will continue to be reassessed. But it's the hydration status that guides us, even though generally speaking, the patient with HHS needs more fluid.
Okay, so some people are raising their hand. Can we take one of the participants raising their hand? Dr. Uba, Can you unmute yourself and ask your question? Okay. We are listening to you. You have the floor. We can't hear you. We're not sure you're talking. Okay, while we're sorting out, let's take some more questions.
Let's take some more written questions.
Let's take some more written questions. Someone wants to know that how do you navigate the issue of normal saline with somebody, an hypertensive patient, and diabetic emergency?
That is not, it's not really an issue at all. Why? Because in diabetic emergency, I mean, the diabetes just takes priority. If the BP goes up, we'll give antihypertensives to counter that blood pressure. So if there's hyperglycemic crisis, the only concern we have with normal saline is actually hypernatremia and high chloride that can develop. So, but the high blood pressure is not really a concern. If the blood pressure goes up, which it often probably doesn't, because a patient with hyperglycemic emergency is usually severely dehydrated and there is a lot of volume loss. And because of that, the blood pressure probably will not go. But if it does, usually we'll just prescribe antihypertensive for the person.
Okay, thank you. Someone wants to know, since we are talking about practical approach, that how do you give deep IM insulin without tiny insulin needles?
Well, giving deep IM insulin is actually is a makeshift thing, and it's a bit difficult to do. The best way to do it is actually to use the insulin needle with a removable needle, and we change the needle on the insulin syringe to a standard needle. I can't remember the gauge now, but the one for a 2 ml syringe. So they change it to that longer needle so that it can go into the it can go as deep into the intramuscular space. Ideally, the ideal way to manage diabetic emergencies, which we do here often, is actually to use the syringe infusion pump, which can just give the insulin IV at a particular rate. Some people try to give insulin at intermittent bolus, okay, but it doesn't work well, and that is not recommended.
Okay, thank you very much. Someone wants to know, I think Dr. Awofisoye answered the question that deep IM insulin is just an appropriate technology for our environment where we don't actually have a lot of insulin pump. Someone wants the formula for iron gap and osmolarity. We put that in the comment box for everybody to see. Thanks for reminding us about that. And let's see the other question that we still have to answer.
I can see one. Someone asked, the one you highlighted.
Yes,
Can we start insulin without serum potassium? So it's recommended that we do not start insulin until the serum potassium result is out. That is a recommendation. But it's something that is difficult to practice in this environment. The truth is that in hyperglycemic emergencies, in a way, there's no rush to start insulin. Actually, it's the rehydration that we should focus on initially. Okay, but most labs where those recommendations were made, most of those hospitals can get their potassium result within 1 or 2 hours. I know many centers may not have that. Even in my center where we do things very fast, it might take even up to 3 or 4 hours before I get potassium sometimes. So it depends. So if you're not sure you can get your potassium on time, then we may still need to start insulin, but it's not recommended. And the reason why it's recommended is because starting insulin in the context of a low serum potassium. Now, the total body potassium is low. We know that. Okay, but if the serum potassium is low, if you start insulin, the potassium can get critically low, and that critically low potassium can precipitate arrhythmias, another problem that may be worse than what we are trying to solve with the insulin. So the recommendation is to have your serum potassium before you start the insulin, but that has to be in centers where you can get your serum potassium within a reasonable period. Okay. That's one of the advantages of managing these hyperglycemic emergencies in a bigger center, so to say.
A lot of questions are coming about different type of insulin. How do you give? But unfortunately, we may not be able to answer all those questions live. But I will allow Dr. Awofisoye to just shed a little briefly on just the different type of insulin, but maybe some that can be used in the context of emergency and some that you cannot use.
Okay, so the many types of insulin, we have rapid-acting insulins and we have long-acting insulins. We have short-acting insulin, rapid-acting insulins, and long-acting insulins. The one we use in diabetic emergencies is the short-acting insulin, which is the soluble insulin. You can also use the rapid-acting, especially the Lispro or the Haswell, but generally speaking, it's the soluble insulin or the regular insulin that we use. The long-acting insulin are not used in hyperglycemic emergencies, but if someone was on it before, we can continue it. And if someone was on, if someone was on it before, we can continue it. And then at the appropriate time, it can be started. But for this session, we won't be able to go into the details of the type of insulin. But mixed insulin is not used in diabetic emergencies. It's used as a pre-meal insulin, usually in a non-emergency state, so to say.
So a lot of people still want to know, how do you negotiate in patients with heart failures, pulmonary edema, and with this lot of fluid?
Okay, so the one thing to note is actually that hyperglycemic emergencies, particularly HHS, is difficult to happen in someone that has a lot of fluid retention. It's less common. Why? Because hyperglycemic emergencies require a lot of dehydration to happen, particularly HHS. Now, in people who have heart failure and reasons why we need to restrict fluid, of course, we give the fluid much cautiously. We don't follow these pathways at all, okay? So we'll give the fluid much cautiously at a much slower rate. Those kind of patients should be managed in an HDU and in centers where there's a CVP line to monitor to see where you're giving too little or you're giving too much. And I will tell you that usually it's better to err on the side of too little than too much. A lot of people make the mistake of mixing hyperglycemic emergencies up with just hyperglycemia. So they see severe hyperglycemia. Don't forget that severe hyperglycemia is not necessarily an emergency. So you see someone with an RBG of 500 milligrams per DL, average of 500 milligrams per DL, and the person has heart failure, and then we try to take it as an emergency, and they're trying to give fluids to crash the sugar. No, that is wrong. If the person does not have acute metabolic complications from that high glucose, then it is not an emergency. All that patient needs is just insulin to control his sugar. Okay, so we don't need to rush fluids for such people.
And before we forget, someone also asked about hypoglycemia, and I promise we're not going to talk about that. How do you manage a patient with hypoglycemia briefly?
Okay, so in managing a patient with hypoglycemia, I actually do have a slide on that. Can we scroll to that slide on the algorithm for the hypoglycemia? So in managing a patient with hypoglycemia, one of the first things we want to do is to assess the severity of hypoglycemia and determine whether the patient can safely eat or not. In a patient that can safely eat, then we give something that contains high amount of sugar, typically a third of a bottle of soft drink or 3 cubes of sugar, or any other thing that is really sugary. Of course, we should make sure that we don't give Diet Coke or all these things that are designed not to have sugar because it won't work, okay? In someone that cannot eat safely, then we should secure an IV access urgently and give 20 mils of 50% dextrose water, and then we maintain with dextrose infusion. Of course, in centers where glucagon injection is available, we can give a shot of glucagon injection to rescue the person out of the hypoglycemia episode. So basically that is it. And of course, the patient needs to be monitored because that's a mistake that we often make as well. Many times the patient is treated for hypoglycemia, sent home, and then the patient comes back even within a few hours with a rebound hypoglycemia. We should always find out the agents that cause the hypoglycemia, and that one guides us on how long the patient needs to be monitored for. We know that the oral sulfonylureas, some of them can act for even more than 24 hours, long-acting insulin, and that will be treated different if it was caused by, for example, a short-acting insulin, which does not act for more than about 8 hours.
Thank you very much, Dr. Awofisoye, for a wonderful time. And I believe our audience too have really enjoyed this topic about diabetic emergency. So today, in the last 1 hour, we've been able to talk about diabetic emergencies, looking at DKA, HHS, and little about hypoglycemia, how they present, and the practical steps for us to take. The other question that we cannot take down, we will answer them in the comments, in the chat box for people to see. So we thank you for following us, and we'll be taking a very short break, about 2 to 3 minutes, to set up for the next next lecture. And the next lecture will be talking about practical approach to heart failure. Thank you very much, and we'll see you in the next 2-3 minutes.